What is the rationale behind using low tidal volume ventilation 6-8 MAG in the management of acute respiratory distress syndrome (ARDS), and how does it impact patient outcomes? Answer: in ARDS, the goal of mechanical ventilation is to minimize ventilator-induced lung injury (VILI). The use of low tidal volumes 6-8 MAG of ideal body weight is based on the understanding that large tidal volumes can exacerbate VILI by causing overdistension of the alveoli, leading to barotrauma, volatrauma, and biotrauma, which further increase inflammation and worsen lung injury. The ARDSNet study, published in the New England Journal of Medicine in 2000, demonstrated that ventilating ARDS patients with low tidal volumes as compared to traditional 12 AAG resulted in a reduced mortality rate and improved oxygenation. Low tidal volume ventilation helps preserve lung compliance, maintain alveolar recruitment, and prevent lung collapse during expiration, which also reduces the shunt fraction, the portion of blood that bypasses oxygenated areas of the lung. While low tidal volumes can improve outcomes, positive end expiratory pressure (PEEP) is also crucial for preventing alveolar collapse and enhancing oxygenation. PEEP prevents atelectasis and increases the lung's functional residual capacity, leading to better gas exchange. Together, these strategies reduce the risk of VILI and mortality in ARDS patients. However, clinicians must monitor for potential complications such as barotrauma and hypotension due to excessive PEEP, which can occur if ventilation settings are not optimized for individual patient needs. 58-year-old male with a history of asthma presents to the emergency department with worsening shortness of breath, wheezing, and tachypnea. He is using his albuterol inhaler more frequently without relief. What are the initial steps in managing an asthma exacerbation in the emergency department? Answer: in the emergency department, managing an asthma exacerbation involves a rapid assessment of severity and timely intervention with bronchodilators and anti-inflammatory medications. The initial steps for management include administer short-acting beta agonists, SABAs. The first-line treatment is albuterol, a SABA which works by relaxing bronchial smooth muscles and reversing bronchospasm. It is delivered via nebulizer or metered-dose inhaler MDI with the spacer, depending on the patient's severity, and ipratropium bromide. In cases where the initial albuterol treatment does not provide adequate relief, ipratropium bromide and anticholinergic agent can be added. This combination of SABA plus ipratropium can provide better bronchodilation and improve airflow. Systemic corticosteroids. Prednisone or methylprednisolone should be administered systemically, either orally or intravenously, to reduce airway inflammation and prevent relapse of symptoms. Corticosteroids can take several hours to act but are crucial for long-term control during exacerbations. Oxygen therapy. If the patient is hypoxemic, oxygen saturation below 90%, supplemental oxygen should be given to maintain O saturation 90%. Monitor response. Continuous monitoring of the patient's clinical status, oxygen saturation, and peak expiratory flow rate is critical. If there is no improvement after initial treatments, magnesium sulfate can be considered for its bronchodilator effects. If the patient remains severely symptomatic or deteriorates, intubation and mechanical ventilation may be required for respiratory support. Mr. Johnson, a 72-year-old male with a history of chronic obstructive pulmonary disease (COPD), presents to the emergency department with acute onset of shortness of breath, hypoxemia, and tachypnea. His chest X-ray shows a hyperinflated lung with flattened diaphragm. What should be the immediate management steps for Mr. Johnson, and when should invasive mechanical ventilation be considered? Answer: in this scenario, Mr. Johnson is likely experiencing an acute exacerbation of COPD, ECOPD, which is characterized by increased shortness of breath, hypoxemia, and respiratory acidosis. The management approach includes oxygen therapy. The first step is to administer oxygen to maintain an oxygen saturation of 88-92%. Excessive oxygen can lead to carbon dioxide retention in COPD patients, so it's important to avoid hyperoxia. Bronchodilators. The administration of SABA, albuterol, and anticholinergics, ipratropium, via nebulizer or MDI is critical for bronchodilation and improving airflow. Systemic corticosteroids. Prednisone or methylprednisolone should be initiated to reduce airway inflammation and prevent subsequent relapse. These are typically given intravenously during the acute phase. Antibiotics. If there is suspicion of a bacterial infection, e.g. pneumonia, purulent sputum, broad-spectrum antibiotics should be considered, especially in patients with a history of frequent COPD exacerbations or those with comorbidities. Non-invasive positive pressure ventilation (PE). BiPAP is beneficial for reducing the work of breathing, improving gas exchange, and preventing intubation. This is particularly useful for patients with hypocapnic respiratory failure, elevated CO levels, and respiratory acidosis. Invasive mechanical ventilation should be considered if the patient develops respiratory arrest as worsening hypocapnia, alter mental status, or is unable to maintain adequate oxygenation despite non-invasive support. How can a clinician differentiate between type 1 and type 2 respiratory failure, and what are the management approaches for each type? Answer: Type 1 respiratory failure, hypoxemic, is characterized by low oxygen levels, a POW 6 mHg within a normal or low carbon dioxide, POCA 50 mHg near relatively low or normal POW. This type of failure often occurs in conditions where there is impaired ventilation, such as COPD, neuromuscular diseases, or drug overdose. The goal in type 2 respiratory failure is to reduce co-retention, which can be achieved with non-invasive ventilation of PV, like BiPAP. If NPPV fails or the patient becomes hemodynamically unstable, invasive mechanical ventilation may be needed. Both types may require careful monitoring of blood gases and adjustment of ventilation settings to optimize oxygenation and ventilation. Monitoring for complications such as barotrauma or hypotension is also essential in type 2 respiratory failure. What are the common clinical findings and diagnostic modalities used to identify a pneumothorax, and what are the management options? Answer: A pneumothorax is the accumulation of air in the pleural space, which can lead to lung collapse. Common clinical findings include sudden onset pleuritic chest pain, dyspnea, and decreased breath sounds on the affected side. Tachypnea and hypoxemia may also be observed. On physical examination, the patient may have hyperresonance on percussion and decreased tactile fremitus. The primary diagnostic modality is chest X-ray, which can show the presence of a collapsed lung with a visible pleural line. Ultrasound can be helpful in identifying a pneumothorax, especially in trauma patients or those who are hemodynamically unstable. A CT scan may be used for a more detailed assessment, especially in cases of complicated pneumothorax. The management depends on the size and clinical severity of the pneumothorax. For small pneumothoraces, less than 3 centimeters, observation with supplemental oxygen may be sufficient, as oxygen helps to reabsorb the air. For larger or symptomatic pneumothoraces, needle decompression followed by chest tube placement is required to evacuate the air and allow lung re-expansion. In cases of recurrent pneumothorax, pleurodisese, either via chemical agents like talc or mechanical means, may be necessary to prevent further occurrences. MS. Carter, a 45-year-old female with a history of deep vein thrombus DVT, presents to the emergency department with sudden onset of pleuritic chest pain, dyspnea, and tachycardia. A CT pulmonary angiogram confirms a diagnosis of pulmonary embolism. What are the treatment options for her condition? Answer: The diagnosis of pulmonary embolism, P, in MS. Carter requires prompt intervention. The treatment approach for P involves anticoagulation to prevent further clot formation and thrombolysis, or surgical intervention in severe cases. Anticoagulation. The initial management of P includes anticoagulation with low molecular weight heparin, LAUSH, or unfractionated heparin, followed by oral warfarin or direct oral anticoagulants, DOACs, such as apixaban or rivaroxaban for long-term therapy. Heparin is commonly used in the acute phase, while DO or CS can be used for outpatient management. Thrombolysis. In massive PE, causing hemodynamic instability or shock, thrombolytic therapy with TPA, tissue plasminogen activator, may be indicated to dissolve the clot. This treatment carries the risk of bleeding and should be reserved for patients with life-threatening PE. Inferior vena cava IV filter in patients with contraindications to anticoagulation or those who have recurrent PE. Despite anticoagulation therapy, an IVC filter may be inserted to prevent further emboli from reaching the lungs. Supportive care. In addition to pharmacological interventions, MS. Carter should receive oxygen therapy if hypoxic and may need mechanical ventilation if respiratory failure develops. What is the role of corticosteroids in managing acute exacerbations of asthma, and how should they be administered in the emergency department setting? Answer: Corticosteroids are crucial in the management of acute asthma exacerbations because they help reduce airway inflammation and prevent relapse of symptoms after the acute phase. In the emergency department setting, systemic corticosteroids such as prednisone or methylprednisolone should be administered early. These medications can be given orally or intravenously depending on the severity of the exacerbation. Oral steroids are often preferred in mild to moderate exacerbations, while IV steroids may be used for severe cases or those who are unable to tolerate oral medications. The corticosteroids take several hours to reduce inflammation, so they are often used in conjunction with bronchodilators, e.g. albuterol, for immediate symptom relief. Corticosteroids can shorten the duration of the exacerbation, reduce the need for hospitalization, and decrease the risk of relapse after discharge. They also help prevent airway remodeling in the long term when given during frequent exacerbations. Typically, prednisone is given at a dose of 4060 mg daily for 5-7 days, depending on the clinical situation. In addition to corticosteroids, other supportive measures such as oxygen therapy, nebulized beta agonists, and anticholinergics should be part of the treatment regimen. In the management of community-acquired pneumonia (CAP), what are the first-line antibiotics, and how does their selection depend on the patient's risk factors and the severity of illness? Answer: the management of community-acquired pneumonia (CAP) depends on the patient's age, comorbidities, and the severity of illness. In mild cases, amoxicillin or a macrolide such as azithromycin is typically sufficient. For moderate cases, combination therapy with a beta-lactam ceftriaxone and a macrolide or doxycycline is often used to cover Streptococcus pneumoniae, Haemophilus influenzae, and Mycoplasma pneumoniae. For severe CAP-E.G. requiring hospitalization, the initial treatment typically includes beta-lactam ceftriaxone, piperacillin tazobactam in combination with either a fluoroquinolone levofloxacin or a macrolide azithromycin to cover both typical and atypical pathogens. In cases where there is a high risk for MRSA or Pseudomonas aeruginosa, additional coverage with vancomycin or linezolid may be warranted. In patients with significant comorbidities or recent antibiotic use, broader spectrum coverage may be required. Guideline: Infectious Diseases Society of America (ITSA) guidelines provide a detailed framework for managing CAP based on patient risk factors and severity of illness. What is the key pathophysiological mechanism behind acute respiratory failure in chronic obstructive pulmonary disease (COPD) patients, and how does non-invasive positive pressure ventilation (BiPAP) help manage this condition? Answer: in COPD, acute respiratory failure commonly results from airflow obstruction, air trapping, and alveolar hypoventilation, which leads to hypercapnia, high CO levels, and hypoxia at low oxygen levels. This is compounded by bronchoconstriction, increased mucus production, and reduced lung compliance. The inability to exhale fully leads to the accumulation of carbon dioxide in the blood. The primary goal in managing acute respiratory failure in COPD patients is to reduce the work of breathing and improve gas exchange. Non-invasive positive pressure ventilation (BiPAP) is an effective intervention in this scenario. BiPAP provides inspiratory positive airway pressure (IPAP) to assist in ventilation and expiratory positive airway pressure (EPAP) to keep airways open and prevent atelectoses. The PAP helps reduce the effort required to breathe and facilitates carbon dioxide elimination by improving alveolar ventilation. The PAP helps maintain lung volume and reduce airway collapse during exhalation. This improves the efficiency of gas exchange, prevents respiratory muscle fatigue, and reduces the need for intubation in many cases. Guideline: American Thoracic Society, its guidelines recommend BiPAP for patients with hypocapnic respiratory failure associated with COPD exacerbations. Mr. Thompson, a 62-year-old male with a history of pneumonia, presents with worsening dyspnea and fever after being on a ventilator for several days. A chest X-ray shows new infiltrates. What is the most likely diagnosis and how should it be managed? Answer: Mr. Thompson's presentation is highly suggestive of ventilator-associated pneumonia (VAP), a common complication in mechanically ventilated patients, particularly those who have been on a ventilator for more than 48 hours. VAP is caused by bacterial pathogens that colonize the respiratory tract and cause infection in patients with impaired immune defenses and alter respiratory mechanics. The most likely pathogens include Pseudomonas aeruginosa, methicillin-resistant Staphylococcus aureus MRSA, Enterobacteriaceae, and Streptococcus pneumoniae. The initial management includes empiric broad-spectrum antibiotics to cover both gram-positive and gram-negative organisms, with adjustments made based on culture results. Common empiric therapy includes piperacillin tazobactam or cefepime for broad-spectrum coverage, along with vancomycin or linezolid to cover MRSA. Antifungal therapy may be considered in patients with risk factors for fungal infections. If the patient is at risk for multi-drug-resistant organisms, a broader spectrum of antibiotics may be needed. The use of sedation minimization, elevating the head of the bed, oral care protocols, and early extubation are preventive measures to reduce the risk of VAP in mechanically ventilated patients. A 32-year-old male is brought to the emergency department following a motorcycle accident. He is semi-conscious with a Glasgow Coma Scale (GCS) score of 10, and a CT scan reveals a subdural hematoma. What is the immediate management, and how would you decide if surgical intervention is necessary? Answer: initial management of a TBI with a subdural hematoma includes Airway and breathing. Ensure adequate oxygenation and ventilation, and if needed, intubate to protect the airway, especially with a GCS of 10. Circulation. Ensure hemodynamic stability with IV fluids and blood pressure management. Neurological monitoring. Continuous monitoring of neurological status, including GCS, pupil response, and motor function, is essential to assess for deterioration. Imaging. The CT scan has already revealed a subdural hematoma, and serial imaging may be required to track any progression. For surgical intervention, surgical criteria. Indications for surgery include significant hematoma expansion, midline shift on imaging, or worsening neurological status, e.g., decreasing GCS, increasing intracranial pressure. If the hematoma is large or the patient is deteriorating neurologically, urgent surgical evacuation, e.g., craniotomy, may be required. A 45-year-old man is involved in a stabbing incident and presents with shortness of breath, tachypnea, and hypertension. A chest X-ray reveals a large hemothorax. What are the management steps for this patient, and when is surgical intervention indicated? Answer. Immediate management steps for a hemothorax include airway and breathing. Ensure the patient has an adequate airway and oxygenation. Provide supplemental oxygen and intubate if necessary. Chest tube placement. Insert a chest tube to drain the blood and re-expand the lung. This should be placed in the fifth intercostal space at the mid-axillary line. Fluid resuscitation. Administer IV fluids, crystalloids, to correct hypotension while monitoring for signs of shock. Blood transfusion. If the patient continues to lose blood or exhibits signs of shock, initiate a blood transfusion. Surgical intervention is indicated if the patient requires more than 1500 ml of blood initially from the chest tube or continues to drain 200 ml per hour for several hours. Thoracotomy may be required if there is persistent hemorrhage or signs of major vascular injury. A 25-year-old male presents with a complete paraplegia after a high-impact motor vehicle crash. On physical examination, he has no sensation or movement below the level of the two vertebrae. What is the initial management approach for this patient, and what are the key aspects of preventing secondary complications? Answer. Initial management of spinal cord injury site includes spinal immobilization. Ensure that the patient's spine is immobilized using a cervical collar and a backboard until the extent of the injury can be assessed. Airway and breathing. Ensure airway protection and assess for any respiratory compromise, particularly if the injury is at or above the level of that which can affect respiratory muscles. Circulatory support. Administer IV fluids and manage blood pressure to avoid spinal shock. Vasopressors may be required to maintain perfusion. Steroid administration. In some cases, methylprednisolone may be given within 8 hours to reduce inflammation and secondary neuronal injury, though this practice is now debated. To prevent secondary complications, DVT prophylaxis. Initiate deep vein thrombosis DVT prophylaxis as SCI patients are at high risk. Pressure ulcer prevention. Implement regular repositioning and skin care to prevent pressure ulcers. Bladder and bowel management. Begin assessment and management of bladder and bowel function early to prevent complications related to incontinence and infection. Respiratory care. Monitor for respiratory complications, particularly in cases of high-level injuries above. A 60-year-old male is brought to the emergency department after severe trauma with massive bleeding. His vital signs show hypotension and tachycardia, and his hemoglobin is 6 grams still. What are the components of a massive transfusion protocol, MTP, and how do you assess when to stop the transfusion? Answer. The massive transfusion protocol, MTP, involves the following steps. Initial blood products. Administer packed-ready blood set ECS, fresher frozen plasma FFP, and platelets in a balanced ratio, typically 1 for ECE. Fluid resuscitation. In parallel, use crystalloids and colloids, e.g. albumin, to maintain blood volume, especially in the early stages before blood products are available. Hemoglobin and coagulation monitoring. Monitor hemoglobin, platelet count, and coagulation parameters (PT) at dinner. Invasive monitoring. Consider central venous access and arterial blood gas BAG monitoring to assess oxygenation and acid-base status. When to stop transfusion. Transfusion should continue until the patient achieves hemodynamic stability, normalization of blood pressure and heart rate, appropriate hemoglobin levels, generally above 7-8 grams still, and correction of coagulation abnormalities. If there is ongoing hemorrhage despite resuscitation, consider surgical or interventional measures. 50-year-old male is brought in following a high-speed motor vehicle crash. On physical exam, he has unequal blood pressures in the arms, with a markedly higher reading in the right arm. CT imaging reveals a tear in the aortic arch. What is the most appropriate management, and what are the key considerations? Answer: a traumatic aortic injury is a life-threatening condition often seen in high-velocity accidents. Immediate management includes blood pressure control. Beta blockers, e.g. esmolol, should be administered to control heart rate and blood pressure to reduce aortic shear stress and limit the risk of rupture. Surgical repair. Surgical intervention is required, typically a thoracic aortic repair, either endovascular stent graft or open surgery to repair the tear. The decision is based on the location and size of the tear. Immediate transfer. If surgery is not available at the initial facility, transfer to a center capable of performing thoracic aortic surgery should be expedited. Key considerations. Early diagnosis is critical. CT angiography is the gold standard for diagnosis. Multidisciplinary management is essential, involving trauma surgeons, vascular surgeons, and interventional radiologists. Hemodynamic support and fluid resuscitation should be optimized while preparing for surgery. Mr. Roberts, a 28-year-old male, is brought to the ER after a motorcycle crash at high speed. He is tachypneic, hypotensive, and has a Glasgow Coma Scale (GCS) score of 10, indicating altered mental status. His abdomen is rigid and there is bruising over the pelvic region. What is the next step in managing this patient's trauma based on advanced trauma life support battles protocols? Answer: based on ATLS protocols, the next step in managing Mr. Roberts' trauma should be primary survey. First, ensure the airway is patent and establish cervical spine protection, especially given the mechanism of injury. Breathing. Ensure adequate ventilation and oxygenation, addressing any pneumothorax or hemothorax that might be present. Circulation. Begin IV access with 2 large bore IVERSes and start fluid resuscitation with crystalloids or blood products to address the hypotension and signs of shock. Disability. Neurological status. A GCS of 10 indicates a possible head injury, therefore assess for any intracranial bleeding and CT scanning is indicated. Exposure. Fully expose the patient to examine all injuries. Given the bruising over the abdomen and pelvis, a focused abdominal ultrasound, FAST, and CT imaging of the abdomen and pelvis are necessary to identify any internal bleeding or organ damage. The patient's pelvic fractures and abdominal rigidity suggest internal injuries, likely requiring surgical intervention. A 45-year-old male is brought in following a high-energy blunt trauma accident. He is intubated in the field, but upon arrival at the hospital, the attending physician notes that his endotracheal tube TET is not properly secured and there are signs of hypoxia. What steps should the physician take to manage this airway situation and avoid further complications? Answer: in this situation, the physician should take the following steps. Confirm TT placement. Immediately check the placement of the endotracheal tube using a capnograph to confirm end-tidal cone. Verify that it is in the trachea, not the esophagus. Secure the E. Once correct placement is confirmed, secure the E. TT with proper tape or TT holder to avoid dislodgement, which is a common complication in trauma patients, especially if movement occurs. Assess ventilation and oxygenation. If hypoxia persists, consider potential causes like pneumothorax, hemothorax, or flailed chest and perform necessary procedures such as needle decompression or chest tube insertion. Maintain oxygenation. Ensure optimal oxygenation by adjusting the ventilator settings or providing manual bag valve mask ventilation as needed. The key to successful airway management is maintaining a secure and patent airway while addressing any underlying injuries that could obstruct ventilation. A 50-year-old male presents after blunt trauma to the chest from a car accident. His vital signs include low blood pressure, tachycardia, and rapid, shallow breathing. A chest X-ray shows multiple rib fractures, and there is no evidence of a pneumothorax. What is the likely cause of this patient's shock, and what is the appropriate initial treatment? Answer: the patient is likely suffering from hemorrhagic shock caused by traumatic rib fractures, which can lead to pulmonary contusion or hemothorax. Given that the X-ray does not show pneumothorax, the cause of the shock is likely internal bleeding from the lungs or surrounding tissue. The appropriate initial treatment includes fluid resuscitation. Start with crystalloid fluids, e.g. normal saline or Ringer's lactate, to restore intravascular volume, blood products. If the patient continues to show signs of shock, e.g. persistent hypotension despite crystalloid infusion, initiate transfusion with blood prods DECS. Pain control. Provide adequate pain management to prevent respiratory depression or hypoventilation, commonly seen in patients with rib fractures. Monitoring. Continuous monitoring of vital signs and reassessment of the need for more advanced interventions like CT imaging to check for further injuries. A 3-year-old girl is brought in after fall from a second-story window. She is lethargic, has a bruised forehead, and is crying intermittently. Her GCS score is 13. What pediatric trauma considerations should guide her initial assessment and management? Answer: when managing pediatric trauma, the following considerations should guide the assessment and management. Primary survey. Perform the primary survey as per ATLS protocols with attention to maintaining cervical spine protection and ensuring a patent airway. Children are particularly prone to rapid deterioration due to compensatory mechanisms, head injury. Given the bruising on the forehead and altered mental status, there is concern for concussion, epidural hematoma, or intracranial hemorrhage. A CT scan of the head should be considered based on her GCS score and mechanism of injury. Pain management. Administer age-appropriate analgesia to reduce stress and improve respiratory function, as pain can lead to hypoventilation. Fluid resuscitation. Start with IV fluids tailored for pediatric patients, e.g. normal saline or lactated ringers. Monitor for hypovolemic shock, which can occur in the setting of internal injuries. A 25-year-old male presents after a motorcycle accident complaining of severe shoulder pain. On examination, his arm is positioned in an abnormal posture and he is unable to move the shoulder joint. What is the likely diagnosis and what are the key principles in the management of a suspected shoulder dislocation? Answer: the patient is likely suffering from a shoulder dislocation, most commonly an anterior dislocation, which often occurs after traumatic events such as motorcycle accidents. Key principles in management include initial assessment, ensure no neurovascular compromise, e.g. check for pulses and sensation distal to the shoulder before attempting any reduction. Analgesia, provide adequate pain management, often including sedation, prior to attempting reduction. Perform a gentle, controlled, closed reduction under sedation. This may involve traction and counter-traction or manipulation techniques. Post-reduction care. After successful reduction, immobilize the shoulder in a sling and provide follow-up for imaging, e.g. X-ray, to assess for fractures or complications like rotator cuff tears. Mr. Johnson, a 65-year-old male, presents to the emergency department with sudden onset left-sided weakness, slurred speech, and right facial droop. He is unable to lift his left arm or move his left leg. His medical history includes hypertension and atrial fibrillation. On examination, his NIH stroke scale (NIS) score is 14. His CT scan shows no hemorrhage. His blood pressure is 100 to 100 mm Hg. Based on Mr. Johnson's presentation, what would be the most appropriate next step in management and why? Answer: given Mr. Johnson's symptoms and NIHSS score of 14, this presentation is highly suggestive of an ischemic stroke. According to the American Stroke Association (ASA) guidelines, the primary management should aim to restore cerebral perfusion as soon as possible. The key steps include thrombolytic therapy, (EPA). The patient is eligible for intravenous recombinant tissue plasminogen activator, (RTPA), if he presents within 3 to 4.5 hours from symptom onset and his CT scan shows no hemorrhage. Thrombectomy, if the patient presents within 6 hours and has a large vessel occlusion, thrombectomy is indicated. The benefit decreases significantly beyond this window. Blood pressure control. For ischemic stroke, blood pressure management is crucial. According to ASA guidelines, blood pressure should be lowered only if it exceeds 185/110 mm Hg before administering RPA, or if the patient is not a candidate for thrombolytics. In this case, since Mr. Johnson's blood pressure is elevated to 108 to 100 mm Hg, careful management with labetalol or nicardipine is recommended to lower it within safe limits. In a management of status epilepticus, why is it important to administer benzodiazepines first, and what role do antiepileptic drugs, EEDs, play in the treatment of refractory cases? Answer: benzodiazepines are the first-line agents in the acute management of status epilepticus, because they act rapidly by enhancing the effect of gamma-aminobutyric acid, GABA, the principal inhibitory neurotransmitter in the brain. This results in immediate suppression of neuronal hyperexcitability, crucial in halting seizures. Diazepam, lorazepam, or midazolam are commonly used for this purpose. Once benzodiazepines are administered and the patient is stabilized, antiepileptic drugs, EEDs like phenytoin, fosphenytoin, valproic acid, or levetiracetam are introduced to prevent further seizures and maintain long-term control. In refractory status epilepticus, seizures lasting longer than 30 minutes despite initial treatment, additional DS or barbiturates, e.g. pentobarbital, may be required, and general anesthesia, e.g. propofol, may be induced to control ongoing seizures and protect against brain damage. The management strategy for refractory SE follows the American Epilepsy Society's guidelines, which emphasize early escalation of therapy. A 55-year-old female presents with a sudden onset of severe headache, vomiting, and decreased level of consciousness. She has a history of chronic hypertension and smoking. Her Glasgow Coma Scale (GCS) score is 12 and her blood pressure is 210 on 110 mm HD. A CT scan reveals a large subarachnoid hemorrhage. Sir, what is the immediate management strategy for this patient, and why should blood pressure management be handled cautiously? Answer: this patient is presenting with a subarachnoid hemorrhage, sir, which requires immediate attention due to its high risk of morbidity and mortality. The immediate management should include airway breathing, circulation, ABC, secure the airway and ensure adequate oxygenation and ventilation. Blood pressure control. In SAH, blood pressure should be controlled cautiously to prevent rebleeding or worsening of the hemorrhage. Guidelines suggest maintaining a systolic blood pressure (SPP) of 140 mm Hg using medications such as labetalol or nicardipine. This helps to prevent further bleeding while maintaining adequate cerebral perfusion. Head elevation. Elevate the head of the bed to 30 degrees to improve venous return and reduce ICP. Neurological assessment. Repeated neurological evaluations are essential to monitor for signs of vasospasm or increased ICP. Surgical consultation. A neurosurgical team should be consulted immediately for evaluation of potential interventions such as coiling or clipping of the aneurysm. Prevention of vasospasm. Nimodipine should be started to reduce the risk of cerebral vasospasm, a common complication in SAH. Explain the Glasgow Coma Scale (GCS) and its role in the classification of traumatic brain injury (TBIA). Answer: the Glasgow Coma Scale (GCS) is a clinical tool used to assess a patient's level of consciousness and neurological function, especially in cases of traumatic brain injury (TBI. It evaluates three aspects: eye-opening (E), verbal response (V), and motor response (M), with a score ranging from 3 to 15. The GCS is used to classify the severity of TBI. Severe TBI, GC equals 8; moderate TBI, GCS 9, 1-2 mild EBI, GCS 1-3, 1-5. A GCS score of 15 is indicative of full consciousness, while a score of 3 suggests deep coma or brain death. The GCS plays a crucial role in guiding management decisions. For example, a GCS equals 8 often indicates the need for intubation and intensive monitoring, as these patients are at high risk for worsening neurological deterioration. Furthermore, the GCS is used in prognostication and decision-making regarding the need for neurosurgical intervention. E.g., craniotomy and monitoring for complications like intracranial pressure hyperelevation. What is the role of intracranial pressure monitoring in the management of severe traumatic brain injury (TBI), and which interventions are indicated to lower ICP? Answer: intracranial pressure monitoring is crucial in managing severe TBI because elevated ICP can lead to brain herniation, cerebral ischemia, and death. ICP is monitored using a catheter placed in the ventricular system or parenchyma in TBI patients with a GC equals 8 and abnormal CT findings. E.g., hemorrhage, contusion, or diffuse axonal injury. ICP monitoring is indicated to guide management. Key interventions to lower ICP include hyperventilation, mild hyperventilation, targeting POCO around 3540 mm Hg causes cerebral vasoconstriction, reducing cerebral blood volume and lowering ICP. Mannitol, an osmotic diuretic, mannitol draws water out of the brain tissue, reducing cerebral edema and ICP. Hypertonic saline, an alternative to mannitol. This treatment also draws fluid out of the brain and lowers ICP. Sedation and analgesia, use of sedatives such as propofol or benzodiazepines and analgesia to reduce pain-induced ICP elevations. Surgical decompression. In refractory cases, decompressive craniectomy may be necessary if medical management fails to lower ICP. A 35-year-old male presents with severe headache, fever, and a stiff neck. His initial examination shows photophobia and confusion. His lumbar puncture reveals a white blood cell count of 200 cells with predominantly neutrophils, protein of 150 mg/dl, and glucose of 50 mg/dl. What is the most likely diagnosis and what is the initial management strategy? Answer: this patient presents with signs and symptoms consistent with bacterial meningitis as evidenced by fever, headache, photophobia, and neck stiffness. The CSF analysis shows an elevated white blood cell count, predominantly neutrophils, suggestive of a bacterial infection, elevated protein, and normal glucose. The initial management of bacterial meningitis includes empiric antimicrobial therapy, start broad-spectrum antibiotics immediately even before the final diagnosis is confirmed. Common regimens include ceftriaxone or cefotaxime for coverage of Streptococcus pneumoniae and Neisseria meningitidis, vancomycin to cover methicillin-resistant Staphylococcus aureus MRSA. Steroid therapy. Dexamethasone is typically given to reduce the risk of neurological complications such as hearing loss in pediatric patients and to improve outcomes in adults with S. Pneumonia, meningitis, supportive care. Ensure adequate hydration, control fever, and manage intracranial pressure if necessary. In the management of delirium in the emergency department, what are the key differential diagnoses and how should treatment be approached? Answer: delirium is an acute confusional state that can result from various underlying causes. Key differential diagnoses include metabolic causes, electrolyte imbalances, e.g. hyper or hyponatremia, hypoglycemia, renal failure, or hepatic encephalopathy; neurologic causes, stroke, seizures, or infection, e.g. meningitis or encephalitis; toxic causes, alcohol withdrawal, medication side effects, or drug overdose; psychiatric causes, schizophrenia or bipolar disorder exacerbations. Treatment should focus on identifying and addressing the underlying cause. In addition, sedation with haloperidol or lorazepam may be necessary for severely agitated patients, especially those with alcohol withdrawal delirium. Supportive care and close monitoring are crucial in managing delirium in the emergency setting. How does the management of spinal cord injury differ depending on whether the injury occurs at the cervical or thoracolumbar level? Answer: the management of spinal cord injury side depends on the level of the injury. Cervical side injuries at the cervical level often result in quadriplegia, paralysis of all four limbs. Immediate management includes spinal immobilization using a collar and backboard to prevent further damage. Respiratory support may be required if the injury affects the phrenic nerve (BC), which controls diaphragm function. Steroids e.g. methylprednisolone may be administered within 8 hours to reduce inflammation and secondary injury, although its benefits remain controversial. Thoracolumbar side injuries at the thoracolumbar level often result in paraplegia, paralysis of the lower limbs. The primary concern is to prevent complications such as deep vein thrombosis (DVT) and pressure ulcers. Immediate stabilization includes spinal immobilization, and surgery may be indicated for fracture fixation or decompression. What are the clinical features of Guillain-Barré syndrome (GBS) and how is it diagnosed and managed in the acute phase? Answer: Guillain-Barré syndrome (GBS) is an acute, immune-mediated disorder that typically presents with ascending paralysis. Clinical features include progressive weakness and areflexia starting in the legs and ascending upwards. Cranial nerve involvement, including bulbar paralysis, difficulty swallowing, speaking. Respiratory failure may occur in severe cases due to diaphragm paralysis. Diagnosis is based on clinical presentation and lumbar puncture findings showing elevated protein levels in the cerebrospinal fluid (CSF) with normal white cell count, albuminocytologic dissociation. Management includes plasmapheresis or IV immunoglobulin (IVIG) to reduce the immune response and accelerate recovery. Respiratory support if needed, especially in patients with bulbar symptoms. What are the key differences between ischemic stroke and hemorrhagic stroke, and how does the treatment approach differ for each? Answer: ischemic stroke occurs due to occlusion of a cerebral artery, resulting in hypoperfusion and neuronal death. Treatment focuses on restoring blood flow. Thrombolytics e.g. RPA within 4.5 hours if no contraindications exist. Thrombectomy for large vessel occlusions within 6 hours. Blood pressure control is aimed at maintaining cerebral perfusion without increasing the risk of rebleeding. Hemorrhagic stroke. This occurs due to rupture of a blood vessel in the brain, leading to intracranial hemorrhage. Management focuses on controlling bleeding and preventing elevated blood pressure. Control is crucial, aiming to prevent further bleeding. Surgical intervention may be necessary for clipping or coiling aneurysms. ICP management includes hyperventilation, mannitol, and head elevation.